Hello, good afternoon. We're going to continue our discussion on the immune system. It shouldn't take too long. We're almost there. Just, a couple more slides to go. And hopefully we can start on lecture 4 today as well. So just a quick recap. Last class, we talked about the different kinds of adaptive immunity. We can separate it into passive immunity or active immunity. Basically, for passive immunity, the host does not make their own antibodies. Something else or someone else is going to be providing the antibodies for the host. As soon as the antibody goes into the host, they are going to have immediate protection. But because they did not make the antibody themselves, it is not going to be a long lasting effect. It's just going to be like a short-term protection. As for active immunity, the host has to make their own antibodies, and in the process of doing so, they will also create memory cells, and these memory cells will stay in the host's body for a very long time, providing long-term protection. But it does take some time to select the naive T cell and the naive B cell. So active immunity might not be available right away. It takes some time before the protection is going to be there. So passive is short-term but immediate, but active is long-term and non-immediate. Within each type, we talk about how there could be natural or artificial version of it. Natural means there's no injection essentially, and artificial means some kind of injection occurs. In the case of passive, we are directly injecting the antibodies either as a way for prevention or protection or as a treatment, whereas in artificial active, we are injecting like a dead or weakened version of the pathogens. Okay, so they're just like different examples here. Let's take a look at the PowerPoint slides. Okay, this is a very long question. I'm just gonna do it with you. Let me read it to you first. T cells are immune cells that fight infection. In T cell therapy, some T cells are removed from a patient's blood. Then the cells are changed in the lab so they have receptors that allows them to recognize the cancer cells. Okay, so basically you harness the T cells from a person, you kind of modify them in a dish to allow them to recognize cancer. Right? Cancer is harder for your white cells to recognize generally because they have very similar cellular pattern as your healthy cells, right? So, your immune system is not trained to do that. So this T cell therapy involves taking the T cells out, you kind of educate them on what the cancer cell looks like, and then you put them back into the body. For this to work, the receptor must do all of the following except, so let's see. Number one, recognize an antigen that is found only on cancer cells and not on other somatic cells. Somatic cells are bodily cells, right? So this needs to happen. This needs to happen because you don't want the T cell to be attacking your healthy cells, right? So it has to identify something that's unique to the cancer cells. We are looking for the exception in these statements. Number two, recognize an antigen that constantly mutates in cancer cells. Now, that actually is the answer. That is the exception. It's impossible, as you learn, you should know by now, right? It's impossible to create a receptor that can constantly recognize something that's changing. The receptor is fixed. And once you make the receptor, no more changes can happen to the receptor. And so the shape, the antigen that it recognizes is gonna be fixed. If the antigen changes, then this receptor is no longer useful. It's the same idea as why we have to get new vaccines for COVID, right? Every time there's a new variant, basically the old receptor that we had from the T cells, the old antibodies that we made are no longer useful for the new one, right? Because it keeps on changing. So that's the exception. That's something that doesn't need to happen for this therapy to work. Trigger clonal expansion once it binds to target antigen. Yeah, that's how you get the effectors. You gotta make a pool of naive T cells and naive B cells, and then they will differentiate. They will specialize into effectors. Effectors are things like killer T cells, memory T cells, so on and so forth, right? Produce effector cells that will attack the cancer cells. Obviously, that's something that's needed in a therapy that is going to be effective. So the answer is B.
Vincent, this is a part of immunotherapy.
Is this part of what? I'm sorry, you got cut off there. One more time.
Immune therapy.
Immunotropic.
Yes, for the patient.
Oh, is it a type of immunotherapy? Is that what you mean, or am I misunderstanding?
Yes.
Yeah. This is an example of
Yes.
immunotherapy where you take the cells out and you kind of engineer it and then you reintroduce it. Yeah, immunotherapy, exactly. Okay, you guys should be able to do this one. All right. Please give it a try. Okay. While you do that, I'll be right back. Okay, so what do you think this is an example of? Okay, I'm gonna end the poll there. So early in the COVID-19 pandemic, oops. Some hospitals are collecting plasma from blood donated from recovered patient. Okay, so in the plasma, there are presumably antibodies that will fight the virus, right? And then you're gonna use this to treat other infected patient. So that's artificial passive. Okay? It's artificial because you're doing some kind of injection, and it's passive because the person who's infected did not make the antibody themselves, right? You're receiving antibodies from someone else. It turns out this was not very effective. They just couldn't get the antibodies to a high enough concentration for it to be effective. But it was something that they tried. All right, let's talk about something else now. How many diseases? How many pathogens? I would say how many pathogens have humans wiped out completely in the history of mankind? What are some guesses? How many pathogens? Okay, bacteria, viruses, fungus, parasites. How many pathogens have we humans completely wiped out in the history of mankind? Any guesses? Give me some numbers. What do you think? No wrong answer, just a guess. No guesses, not even ballpark guesses. Less than 10, more than 20. Anybody? You can type it in the chat. Just want to see what people think. 100. Very, very optimistic, Nika. That's a good guess. Anyone else? How many pathogens have we wiped out? One more guess. You guys are no fun. The correct answer is 1. Right? So we have only successfully completely wiped out one pathogen, and that is smallpox. Okay? Smallpox looks like this. Is a virus. It's caused by the variola virus. And people who have smallpox, smallpox, would have a fever. They would have a very distinctive rash that would kind of slowly spread throughout the body. Most people will recover from smallpox, but about 30% who are infected with smallpox will actually die. And sometimes those who survived, they would have these permanent scar on them. I mean, this is a very extreme case, but you know, they would have these scars on them, and sometimes it would left them with a blind eye as well. So it's a very serious disease, and it was causing a lot of people to die in the past. And so what happened was, there was this English physician. His name was Edward Jenner, and in the late 1700s, he came up with the concept of vaccination, basically. Okay, so he's sometimes credited as the father of modern vaccination. So what he did was, he noticed the milkmaids. So I guess he lives in a pretty wealthy family. He has had these milkmaids that milk the cows for him, and he noticed the milkmaid will get something called cowpox. Okay, so cowpox is not deadly. Like cowpox they catch from the cows, from milking the cows. Okay, and he noticed that the milkmaid who caught the cowpox does not show any symptoms of smallpox. Like they don't get smallpox basically. So this is the story. The cow was named Blossom, and the milkmaid would milk the cow, milk Blossom, and Blossom had these cowpox on the udder. Udder is where you squeeze to get the milk, okay? And so the milkmaid would catch the cowpox, and they would get these sores on the hand. It's not comfortable, but it's not deadly. So there was a milkmaid named Sarah, right? And Jenna, the doctor, right? He noticed that Sarah recovered from the cowpox, and she seemed to be not getting smallpox at all. So he had a theory. Okay? His theory was that if a person catch cowpox and recovers from it, they will gain immunity for smallpox. So to test his hypothesis, he took the gardener's 9-year-old son. Name was James Phillips, okay? And he gave the boy cowpox. Which of course is not a very ethical thing to do, right? Something like that would definitely not be allowed these days. Okay, but back then the ethical guidelines were a little bit blurry. Right? So what happens is, afterwards the boy recovered from the cowpox as expected, and then he did something crazy. He exposed the boy to smallpox, right, multiple times, and see if he's gonna catch the disease. Right. So luckily he was right about the cowpox giving the boy protection for smallpox. Otherwise, the boy would have likely died, right, from exposure to smallpox. And that created the first vaccine. Now, it turns out that Jenner was really lucky in terms of his prediction and hypothesis, because we know now, after learning the lesson, I hope you know, that the antibodies you make from for one disease is not good for another, right? Like you make the antibodies for chickenpox is not going to be good for the flu, right? Because the antibody is very specific, right? It turns out the cowpox and the smallpox are similar enough that the antibodies that was created in the body for the non-lethal cowpox, turns out that also works for recognizing smallpox, right? So that is just coincidence, and they begin vaccinating everybody with the cowpox, and by the turn of the century, the smallpox is completely eradicated. Okay, so the diseases no longer exist. Right? So Blossom, which is the cow, when it died, the hind was preserved, and I think the English gave it to Canada as a gift or something. I forgot what the full story is, but if you go to U of T next time downtown, in the medical science building, that's where you're gonna find the cowhide. All right. So sometimes we do this. Sometimes we have we take vaccines for another version of a disease, and then it creates immunity for something else. Does anybody have a scar on their arm, like on the left arm if you're right-handed, usually like around this area? There's like a little scar. Anybody? Usually, some people have. Yeah. Do you know what that is for? Anybody know what that shot was for?
BCG.
BCG. That's right. What's a BCG vaccine? What is it? What disease does it protect you from?
Tuberculosis.
That's right. BCG vaccine is given to protect you from tuberculosis or TB. Okay, tuberculosis is a bacteria that infects the lungs and gives you this nasty cough and it's not good. Okay, and so many of us are vaccinated for TB using the BCG, but the BCG is actually the cow version of the disease. Okay, and it's a live vaccine. And the cow version is not deadly, or it doesn't affect us. I should say. Okay, it doesn't cause disease in human, but the cow version is very similar to that of the human version. So when your body makes antibodies for the cow thing, it also protects you from the human form. Okay, so that's why you have a scar. Right? Apparently, the scar tells you that the vaccine is working. I was told. My scar got really bad. Like it's really big and really gross looking. So I guess the vaccine really worked on me. Okay, so that's BCG vaccine. All right, we're gonna talk about some other stuff here. We're gonna talk about what happens when your immune system overreacts. Okay, overreacts. We're gonna talk about what happens when it underreacts. And what happens when it's reacting the wrong way. Okay. So 3 things: overreact, underreact, and then reacting incorrectly. By the way, anybody know what's wrong with the hand here? What kind of disease is this?
Arthritis.
Yes, but not just any kind of arthritis, right? Like, do you know which kind it is, maybe? Just wondering. Yeah, okay, so that most of us are familiar with like osteoarthritis, right? That's the one that, as we age, our joints, because of wear and tear, like we get a little bit inflamed. That's the kind of arthritis that most people are have heard of. This one is rheumatoid arthritis, okay, which is when your immune system attack the tissue and the connecting tissue in the joints, and it causes it to be deformed, and as you can tell, it is very painful. Okay, so that would be like reacting the wrong way. That's an example of how your immune system has turned itself against your own cells, creating a bunch of unfortunate diseases. Yeah.
Is that arthritis, you say?
Yeah, but rheumatoid arthritis. Rheumatoid arthritis, yeah. As opposed to like osteoarthritis, right? Rheumatoid arthritis. Okay. All right, so let's start with overreacting. I mean, it's allergy seasons right now. It's actually full bloom allergy seasons. With all the pollens and stuff like that. You might know what I'm talking about if you suffer from allergies. Okay. I usually don't have a problem with pollens and stuff like that, but the recent years, like past 3 years, I started to have these very severe allergies. Runny nose, watery eyes, itchy skin everywhere. Okay, so that's hypersensitivities to things that are normally harmless to the body. Okay, your immune system is overreacting to harmless things like pollens, but it doesn't have to be pollens. It could be things like animal hair. It could be dust mite. It could be just dust in general, or pollutants, and your immune system is reacting to them as if they are pathogens. And sometimes the reaction can be very, very severe. And it causes the whole body to basically undergo an inflammatory response. Usually, inflammatory response, the way we learn it, is very localized, right? Like you have a cut in the finger, then the redness, the swelling, and all that stuff only happens in the finger. But for very, very severe allergic reaction, we actually call it anaphylactic shock. Anaphylactic shock. That's the whole body undergoing inflammation. And usually common allergens for these kind of things includes, peanuts or nuts in general. That's why like they have nut-free zone at school, right? Because some kids may have a very severe nut allergies. It could also be allergies to like bee sting or penicillin, right? So if you're allergic to penicillin, they actually have to give you another class of antibiotics if you have a bacterial infection or something like that. And what happens is when you have these very, very systemic inflammation, right, your blood vessel is going to dilate, and then the permeability of the capillary is going to increase because of histamine, but not just happening at the finger, happening all over the body. And so your blood pressure is going to drop significantly, and that could lead to a life-threatening situation. In addition, your airway is also going to constrict, making it difficult and sometimes impossible to breathe. For someone who's undergoing an anaphylactic shock, there is a very narrow window by which you can help them. And that's why they should always be carrying an EpiPen, the injection of the epinephrine, which is just another word for adrenaline, is going to counteract the effect of the histamine and basically subside the allergic reaction symptoms. Okay, but this is extreme. Okay, like most of us, the allergies are not like that. Most of us allergies are just like annoying. It's an inconvenience, but for some people, right, it could be life threatening.
Professor, I have a question.
Sure.
So in hypersensitivity, so the cause of hypersensitivity lead to anaphylactic shock?
Yeah, exactly, right. But like they are both hypersensitivity, but like regular seasonal allergy is just like a very mild version. But anaphylactic shock is like take it up to the next level, right?
Okay.
Yeah. This is just very interesting thing I read about. I want to tell you guys about. It's not going to be on the test, okay? But there is this tick. Tick is like the things that could like latch onto your skin and take a bite out of you, right? So there's this tick. The tick is called the Lone Star tick. Lone Star tick. It's found in the States. And if you get bitten by one of these ticks, then you cannot eat meat ever again. Okay? You become allergic to meat. Right? So I remember watching this news clip, right, about this man. He loves to hunt like wild meat, like deer and I guess bears and whatnot. And he has a whole fridge of these like game meat that he has hunted, and he was saving it for like special occasion to eat them or something. But then one day he got bitten by this tick, and he can't eat meat anymore. Right? He was so sad in the in the clip. Right? It's like, oh, I don't know what to do with all the all these game meat that I worked so hard to hunt for. So that is a very interesting thing. Sometimes getting bit by an insect, which has nothing to do with meat, is going to create allergies that you never had before. So if you're interested, you can look this thing up. All right, that's the yeah, exactly, Jackie. You read about that. Very good. Yep, excellent. So, or did you just look that up? Maybe you heard about it. Anyway, so that is the wrong kind of reaction. Okay, that is the wrong kind of reaction. Sorry, that was the overreaction that we were talking about. Okay, reacting to something harmless, but creating quite a bit of side effects. The next thing we're going to talk about is the wrong kind of reaction. Right? When we say wrong kind of reaction, we're talking about how your immune system fails to distinguish self versus non-self. One of the characteristics of your immune system is to be able to tell apart what belongs to the body and what does not. Right? For example, in the thymus, the T cell is supposed to do the tolerance test. Right? If it recognizes something that is in the body, you're supposed to destroy the T cells and not let it come out. Right? But sometimes that process failed, and what ended up happening is you have these auto-reactive T cells that are going around in the body, and that causes a bunch of autoimmune diseases. Some of these you probably have heard of. Okay, lupus is a common one that people have heard of. Multiple sclerosis. It's like when the T cell attacks your nerve cells, and then they cannot communicate with each other anymore. Right? So that's going to lead to weakening of the muscle at the beginning and eventually paralysis. If they destroy the nerve cells between the brain and the lungs, then you can't breathe, right? And then you would die. Some of these are a little bit strange that you might not have heard of it. Rheumatoid arthritis, we just talked about briefly. There's inflammatory bowel disease, and a bunch of other ones. So this one is called Graves' disease. I'm just going to briefly tell you about it. We actually will come back to this later on in lecture 12. Basically, your body creates these self-reactive, or auto-reactive antibodies that would be stuck to the thyroid. Okay, so one of the things your thyroid gland does is it produces hormones that turn up your metabolism. Right? So when these autoreactive antibodies are stuck to your thyroid gland, the thyroid gland is always switched on. It keeps on pumping out these hormones that keeps on turning up your metabolism. So you would experience uncontrolled weight loss despite eating a lot. You will keep on burning up everything. You're gonna have irregular heartbeat. You're gonna be intolerant to heat, very agitated all the time, and you will always also have this bulging eye symptom. Okay, this is the official name for the bulging eyes. Okay, I can't pronounce it, so I'm not going to try. And what happens is the antibodies that binds to the thyroid, they actually also binds to the muscle around the eyes, causing it to become inflamed, and that's why the eyes are a little bit protruded. Right? So that's autoimmune diseases, which is just one of the many. And I'm sure you have other ones that you have heard of, but we're just going to keep it brief.
Is this different from hyperthyroidism?
Very good question. Okay, so this is one example of hyperthyroidism. Okay, when we say hyperthyroidism, it means your thyroid is being overly active. So one cause of overly active thyroid is Graves' disease, but there are other causes of hyperthyroidism. So this would be like an example of why there would be hyperthyroidism. Okay?
Thank you.
Yeah. All right, so last but not least, we have the underreaction. Okay. Overreaction is like allergies. Wrong reaction is autoimmune. And now we have underreaction, which is immunodeficiency. Okay. Immunodeficiency, as the name implies, is a deficiency in your immune system. Okay. Your immune system is basically not active enough. Okay, it's not active enough. So there are two kinds of immunodeficiency that I want you to know. There is primary immunodeficiency or immune deficiency. Same thing. You can say it as two words or one word together. Right? And then there's secondary immune deficiency. Primary means the person is born with it. Secondary means the person caught the condition. And now you probably have some questions about that in a bit, but let me talk about the primary one first. A primary immunodeficiency, an example of that is something called SCID, which stands for severe combined immunodeficiencies. Okay, severe combined immunodeficiency. So people who are born with SCID, they have zero adaptive immunity. Okay, they have zero adaptive immunity. They might have some innate immunity, but adaptive is completely gone. So these individuals, they are going to not be able to fight off any kind of infection. Okay, now, if you remember the genetic stuff that we learned last time, it turns out the SCID, this condition, is an X-linked condition. Okay, and if it's X-linked, you might know that it affects male more than female, right? So, anybody have heard of the bubble boy before? Bubble boy, maybe. Doesn't look like it. Okay, so I'm going to briefly tell you about it. Okay, so bubble boy. Oh yeah, good. Fatima had heard of it. The bubble boy was a boy that was born with SCID. Right? And because he doesn't have immunity, he basically would die just from being exposed to the pathogens in the air. And so he was kept in a bubble like this, right? The whole life. His whole life he was kept in a bubble. The bubble is sterile. There's no germs or bacteria or pathogens of any kind in the bubble. The parents cannot directly touch the boy. That's what these holes are for. These holes are basically like glove holes for the parents to put their hands in and interact with the boy. And everything that's given to the boy has to be sterile before being put in the bubble. And what happened was around age 11 or 12, I think, he was able to receive bone marrow transplantation from his sister. Okay, before then it was not the medical technology was not there yet. Okay, but then they figure out how to do it. If to do bone marrow transplantation for between siblings, even though the match is not 100%. His sister, is this a movie or real? This is real. This is real. Okay, but there was a movie made based on this boy. Okay, so this is for real. Okay, someone asked if this was a movie or not. There is a movie about it, but this is real. Okay, so around 11 or 12, what happens was he received the bone marrow transplantation from the sister, and the sister doesn't have the condition. Okay, and you can try to imagine how this would work, right? Because the immune cells, the white cells, came from the bone marrow. There are stem cells in the bone marrow that makes all the blood cells, right? Remember hematopoiesis, right? So by getting the fresh bone marrow from the sister, the hope is that these stem cells from the sister will replenish the boy's entire immune system. Okay, so he was doing well for a little bit. He even get to come out, play outside for the first time in a decade in his life. Okay, however, soon after the surgery, his health got really, really, really bad all of a sudden, and it was discovered that he had a type of leukemia, and then he died shortly after that. So what had happened was that there is a virus that's called EBV. Okay? EBV. You can look it up. Okay, it's called the EBAR virus, and it hides in people's DNA. Okay, they hide in people's genome, and usually, if you have a healthy immune system, your immune system would keep it in check. It would suppress it, and the virus is not going to do anything. But if your immune system goes down, or in this case, the boy who actually virtually didn't have any immune system, the virus will come out. Okay, so along with the bone marrow transplantation, the boy got the EBV from the sister. Okay? The sister was fine because her immune system suppresses the virus, but the boy was not able to suppress the virus, and the virus is known to cause things like leukemia, and that's how he died. Okay. Nowadays, though, people who are born with SCID, they are being treated with gene therapy. Okay, now we understand exactly what's wrong with which genes. By delivering the correct version of a gene, we learned this in biotech last semester, right? We are able to help some form of SCID. Okay, so this is primary immunodeficiency because the person is born with it. Okay, if you don't have SCID, you're not going to catch it. That's basically what it is. Any questions before I move on to secondary?
Vincent, how they diagnose this boy that back then?
Oh, that is a good
Di-
question. Yeah, yeah, you know what? I never thought of it because nowadays you can screen for these things with genetic testing, right? But I'm not sure how they knew. That's a good question. I'm gonna look that up. Okay,
Okay, thank you.
maybe there was a family history associated with it. I'm not 100% sure. Okay, secondary immunodeficiency. This is something that the person would catch. Okay, now when I say catch, they could catch it later on in life, or some babies, as you might know, because the mother is infected with HIV, they caught it from the mother as they are being delivered, right? So, you know, some people say, oh, but wouldn't that count as you are born with it? Not really, okay, because you still have to catch it. It's not like it's not in your genes, right? Like you're not born with the genetic defects in you, right? So like the virus HIV is going to cause AIDS, and the virus causes your adaptive immunity to be gone by targeting macrophages as well as other APCs. APCs, if you remember, stands for antigen presenting cells, right? These are cells that will, you know, eat the pathogen and then put it on the surface and then help activate the naive T cells, right? We only learn macrophage as an example of APCs, but there are other APCs as well. So the HIV virus will attack all these APCs. Without the APCs, you cannot activate naive T cells, right? You cannot do the clonal expansion. That's how the HIV virus cripples the entire adaptive immunity. And if you are lucky to activate the active immunity, the helper T cells that you make in the end will also be targeted by the virus. And if you take away the helper T cells, then you cannot activate naive B cells, and your ability to make antibody is also gone. Okay. Now, there are some people, just very briefly, okay, there are some people who are immune to HIV. Okay? They cannot get AIDS. Right? They have a special mutation on their white cells. Okay, so the HIV virus can only get into these white cells, these APCs and helper T cells, if they have a specific protein on the surface of these white cells. Okay, it's kind of like a door for the virus to go in. These people with the mutation, that door has changed. The shape is different. The virus does not recognize it and therefore cannot infect those cells. Okay, if you want to look it up, the receptor is called CXCR4. Okay, it's a very, very rare mutation. Okay, very, very few people has this. But when they do have this mutation, they are immune to HIV. There was a few cases, okay, in that we know of where a person had HIV. Okay, they have AIDS, and then they needed a blood transfusion. And for some other reason, they need a blood transfusion, okay? Sorry, not blood transfusion. They need a bone marrow transplantation, okay? So let me backtrack again. Let me start again. There were some people who had AIDS, okay? And they needed a bone marrow transplantation for some other reason. Okay? I think it was leukemia or something like that, okay? So they needed a bone marrow transplantation. And then they were able to find a suitable donor. And then the donor donated the bone marrow, and then they got new bone marrow, and the leukemia went away. And then what's really surprising, the first time this happened, which was really surprising to the doctors and the researchers, was that not only was the leukemia cured, but the HIV was also gone. Right? The AIDS was gone. Right? So what happened when they took a closer look, the donor who donated the bone marrow happens to have this mutation, the one that gives them immunity to HIV. And so when they transplant the stem cell over in the bone marrow, the stem cells start making white cells for the AIDS patient that has the mutation. So now the virus has no, they cannot infect anymore. And then the person got cured of AIDS, right? So for the longest time, there was only one case. The person, I think, is Timothy Ray Byrne. I think that was his name. Okay, but since then, there are at least 3 or 4 other cases of similar. So they're trying to, like, reproduce this condition, right, to see if they can come up with some kind of cure. Like on its own, this is really rare because it's already rare enough to find suitable donor for the bone marrow, and on top of that, right, the mutation I told you about is also very rare, right? So what's the chance that you have a suitable donor who also happens to have the mutation? Chance is 1 in a billion, right? Literally. So anyway, that's that.
So, Miss Vincent, this mutation in the donors didn't make any problem for them, like health problem
No, yeah,
for
no.
donors.
That's right. So like this is just I know I say a mutation makes it sound like that bad thing, right? But think of it more as like a genetic variation. I remember we talk about these SNPs that we can have, right? Like maybe on you it's like AAT, but on that person is AAG. It's just like a subtle change that caused the shape to be different, but no other health effects otherwise.
Thank you.
Okay. All right. Which of the following is an example of autoimmune disease? I'm just going to tell you. If you were paying attention, you should be able to tell me. The answer is Graves' disease. That's the one with the protruding eyes. Right? Anaphylactic shock is nut allergies. AIDS is secondary immunodeficiency. SCID is primary immunodeficiency. And that is it for lecture 3. Lots of information, but I hope I've explained it in a clear manner. Any questions before we move on to number 4?
Vincent, so is Graves' disease primary?
Oh, Graves' disease is autoimmune disease, so it's not primary or secondary. We only use primary and secondary to describe immunodeficiency.
Oh, okay.
Okay. So yeah, if the person is born with it, like SCID, that's primary. If they catch it, like AIDS, that would be secondary.
I a little confused, Professor.
Well, yeah.
AIDS, you said is not like transfer from mother to fetus, only when the kid's delivered, yes? So
Yeah, so the HIV,
AIDS, yes,
it's
the AIDS
transfer.
is on her blood, yes.
Yeah, it's a
Her
transfer
mother.
body fluid, right? So
Yeah.
when the baby comes out, it's inevitable that there's going to be contact with the mother's fluid, right? And that's how they catch it, basically.
But until the baby born, the baby's free from AIDS.
I think so. Yeah, I think so. I think the placenta is and the womb is gonna protect the baby from the virus. But that I'm not 100% sure. Maybe let me just quickly Google it. Does a baby catch HIV in the womb? Okay, so apparently it can happen in the womb as well. Okay, but if they know, according to what I'm seeing here, if they know that the mother is infected, they can actually give them HIV medicines, like to the baby, and that will reduce the risk to 1% or less, according to what I'm reading right here. Okay.
Thank you, Professor.
Yeah. That is it. Okay. Now I know it's still a little bit early, but since we finish one lecture already. Why don't we take an early break, just 5 minutes for you to catch your breath, and maybe print some notes. And then we're gonna continue with lecture 4. Okay, let's come back together at 1:20. See you in a bit. Okay, so this is going to be the last lecture that I'm going to teach you, and and then we're going to have we'll finish it up on Thursday, and then we're going to have a test review next week, and then that will be it for Unit 1. So let's start with some basic stuff. This is actually very easy, right? The respiratory system is very easy compared to the other stuff that you've done. So when we breathe, we try to get the oxygen from the air all the way to our cells. And in order to do that, there are several barriers and layers that we have to go through, starting with getting the air from the environment into our lungs. Right, so that exchange is called pulmonary ventilation, which is basically just breathing in and out. Breathing in and out. When you breathe in, oxygen goes in. When you breathe out, carbon dioxide comes out. Yeah. I mean, it's not pure carbon dioxide. There is oxygen coming out as well. Right? That's why.
Vincent, sorry, can you repeat that? When we breathe in, what comes out?
When you breathe out, carbon dioxide comes out.
Oh, okay.
Yeah, but not pure carbon dioxide, right? There is going to be oxygen in it as well. Right? That's why when people do like mouth-to-mouth resuscitation, when they do like CPR on a person, that's why it works, because you're breathing out oxygen as well. Okay, but mostly carbon dioxide when it comes out. After it gets into the lungs, you will have to get the oxygen into the blood, and that exchange is called external respiration. Okay. The location of a gas exchange is alveoli, alveolus for singular, and wrapping around it is going to be blood vessels. I don't know if I told you this last semester, but if you don't understand this, that's okay. We're gonna explain more later. So that's gonna get the air from the lungs and put it into the blood. The blood then circulates throughout the body and is gonna take it to the tissue, and that exchange is called internal respiration. Okay. Once it's in the tissue, meaning it's gonna be in the cells, and inside the cell, you will be doing cellular respiration. Okay, cellular respiration. And we spend like a whole lesson on that, right? Last semester, with the glucose and the oxygen reacting to produce carbon dioxide, water, and energy in the form of ATP. So pulmonary ventilation, external respiration, internal respiration, and finally, cellular respiration. Now, this is your respiratory tract. We breathe through our nose, although we can also do it through the mouth. But normally we breathe through the nose, and it's going to go all the way down to the lungs. Anything above the larynx, above and including the larynx, we call that upper respiratory tract. When you have an upper respiratory tract infection, you usually recover relatively, quickly. So when you have a cold, that's an upper respiratory tract infection. Sometimes the infection can go deeper into the respiratory tract. Then you have a lower respiratory tract infection, and that takes a much longer time to recover. Example of that would be like pneumonia, tuberculosis, right? Even sometimes COVID can cause lower respiratory tract infection. And those, again, it's harder to recover from. Now, I want you to get your study guide out And there's a diagram I want to go through with you. Okay. It's this guy. Okay, so please take it out, and I'm gonna fill in some of these things with you, okay? Now this here is, if you cut the head right in the middle and then you look at it from the side. Right? So it's the mid-sagittal view of the head. Mid-sagittal view of the head. So there are a couple of stuff here that's already labeled. This here, A, that is your nasal cavity. Nasal cavity. It's very spacious inside. Okay, when you do the COVID swab, they stick the Q-tip all the way in. And that's how deep it goes. So that's A, nasal cavity. The function of the nasal cavity is to warms, filters, and moistens the air that you breathe. There's a lot of mucus layer inside. Right? That's gonna help add moisture to it. There's some nose hair inside that helps you filter the air that you breathe, and it warms it up as well, because there are some blood vessels, some capillaries. Now this is your mouth. This big thing here, it's the tongue. Okay, I know it's not labeled, but here, let's just put the tongue. There. This whole thing is the tongue. Okay, it's really strong muscle there. Now, if you push your tongue up, it feels hard, right? That is the hard palate. Hard palate. Hard palate is this bone right here. There are actually two bones there. And that separates the nasal cavity with the mouth. If you curl your tongue back, it feels softer. Right? So this thing right here, this part, that's softer. That is the soft palate. And at the very back, there's a thing that's dangling there. Like if you look into the mirror and you say, ah, like there's the thing that dangles at the back there. That is the uvula. The uvula. Right? So what the uvula does is, when you swallow, the uvula will close the hole that leads to the nose. Right? So that the food's gonna go down. If you try to talk, or your kids, they might laugh and try to swallow at the same time, then the uvula does not close properly, then the food's gonna like go up to the nose, right? And then they might blow like rice pieces out of the nose or something like that. So that's the uvula. All right. Let's take a look at what happens when we breathe. Okay? So when you breathe air, we're gonna go through the nose. Let's just do it the regular way. And the air is gonna go and take this path. Okay? Air is gonna go through an opening at the back, and then it's gonna go to this tube here at the front. So let's go through some of the key things along the way. So E right here, this opening that allows the air to go from the nose down, further down. This opening is called the nasopharynx. So Air goes through here. To enter the pharynx. Okay. So pharynx is, as the diagram shows you, is like all this stuff here. That's the pharynx. You can think of the pharynx as like the throat. The throat. And what does the throat do? The throat is a common passageway for food and liquid and air. Everything that we swallow, everything that we breathe is going to go through the throat, the pharynx. So I'm just going to stop for a moment, let you catch up. Okay. Now, following the blue arrow, we're going to see what else is going to pass through. It's going to exit the pharynx and enter to the next part. So G is the exit for the pharynx, okay? And that's called the laryngeal pharynx. Laryngeal pharynx. So the air exits the pharynx through the laryngeal pharynx. Now we do not want food to be entering the airway. That's why there is a flap here. There's a flap here. Okay, this flap is called the epiglottis, which will, all this stuff is in the PowerPoint, by the way. Like I'm just, trying to go through with you as an overview. The epiglottis is going to seal the airway during swallowing. Okay. We don't want food to go down there. That's why you need to cover it up. All right, there is a opening here. It looks like a slit. That is just a hole. That's just a hole that leads into your voice box. Okay, that hole is called a glottis. That's B. Glottis. Glottis. The epiglottis is on top of the glottis. And then C is further down. That is the larynx. Larynx is the voice box. That's where your vocal cords are. When the vocal cords vibrate, it creates sound. And finally, we have the trachea. The trachea is also called the windpipe. Now, if we are eating, let's say we have food here, food. We're gonna eat with our mouth. It's gonna go to the throat, and then you're gonna swallow it at the back. So the food is gonna enter the throat through the oral pharynx. Okay. Air is gonna go into the throat through the nasal pharynx, but food is gonna go through the oral pharynx. And the food needs to go down the tube at the back. Anybody know the tube that takes the food down? What do we call that? What's the name of the tube that carries the food to your stomach?
Esophagus.
That's right, the esophagus. There you go. Esophagus. Right. So again, the orange thing here, the epiglottis, is gonna seal the glottis when you swallow, so the food's not gonna go down the wrong tube, right? So people eat it and they start coughing. They say, "Oh, sorry, just went down the wrong tube." That wrong tube is the airway. Okay. Now in the PowerPoint, I will also show you that there are a few. Let me choose another color here. There we go. There are these sinuses. Okay. Sinuses are basically like cavities that are found inside the bone. There are 4 pair of sinuses in the head. You don't have to memorize them at this point. I just want to show you that's what they look like. All right. So that's the same picture. You can, match up your stuff later on. So these are the sinuses. Okay. They are, again, basically cavities, empty space that are found inside the bone. And the name of the sinus is named after the bone that they're found in. You don't know these bones yet. You will learn them in lecture 10. Okay. But the sinuses, they are connected to the nasal cavity, and the air that we breathe in can go into these sinuses, and they get warmed up and moistened even further. When you have a cold, the sinuses are stuffed with mucus, and we sound different, right? Because the sound is like bouncing off them differently. Okay, which of the following structure is or are part of the lower respiratory tract? Just go back to this picture here. Anything below the larynx is going to be lower respiratory tract. So that includes all of these things, which would be like the bronchus and the trachea. It's the lower respiratory tract. Which of the following separates the nasal cavity from the oral cavity? Let me launch the poll for you to try this one. We talked about this on the diagram. Do you remember what is it called? Okay, so let's see, right? The mouth is right here. Can you see my mouse? Oh yeah. Okay, it's there. Yeah, the mouth is right here, and the nose is right here. Separating the two is the bone, right? Hard palate. The answer is hard palate. Okay, right there. Okay, so another word about pharynx. Once again, it is the common passageway for everything that we swallow and everything that we inhale. Everything passes through the throat. For air, it will enter the pharynx through the nasal pharynx. Nasal pharynx is E right here. and then it's going to exit through the laryngopharynx, which is right here. Whereas food and water, it enters through the oropharynx. So there are two ways to go in, either through the nose or through the mouth. Okay. As for the air, it's going to exit through the laryngopharynx. Sometimes it's difficult to pronounce things with a Y, but you just change it to I, okay? Then you can see it's laryngo, right? Laryngopharynx. But it's spelled with a Y. Tonsils. We learned about tonsils before in the lymphatic tissue stuff. So there are some tonsils at the back of the throat. There are some tonsils all the way up in the nose. And here the adenoid tonsils are located at the back of the nasal cavity, whereas the palatine tonsils and the lingual tonsils are located at the back of the throat. So let me show you this picture again. You can see, right, there is the one right here. I know it's called the pharyngeal tonsil here, but it's the same thing. It's the same thing as like adenoid tonsils. Adenoid tonsils. Okay, you have more tonsils here. The palatine and the lingual. Right there and right there. Maybe not the best color, but there it is and there it is. We've seen them in at the end of lecture 2. Okay, larynx. Larynx is also known as the voice box, and that is where you will find the vocal cords. To go into the larynx, you have to go through an opening called the glottis. So over here, you don't really see a label for the glottis, but the glottis is basically right here. It's just the opening. There. That's the glottis. And then the flap that's on top of it, that's the epiglottis. Right? Glottis and epiglottis. And in the larynx, you're gonna have the vocal cords, and below the vocal cords, you're gonna have the trachea. So vocal cords is actually do I have a slide coming up for that? I do. Okay, I'll show you in a bit. So there are the different bones and cartilage that's protecting the larynx. And we have a hyoid bone up here, and you can see a little bit of the epiglottis here from the front. This part here, that's the epiglottis. Okay. You have the thyroid cartilage, which is like the so-called like the Adam's apple in men, right? Okay, female also have the thyroid cartilage. It's just not as obvious. And then you have another cartilage down here called the cricoid cartilage. So maybe we can label these guys and the diagram. There's a diagram right here. Okay, just gonna label some of these things. Over here first. This is from the front, okay? This is anterior view. At the top here, we have the epiglottis. And again, in case you forgot what it does, it covers up the glottis when you are swallowing. So the food's not gonna go down, right? To the airway. There's a small bone right here. Like you can maybe you can feel a little bit right here. That is the, it's very high up, so it's the hyoid bone. Hyoid bone. Okay, moving down, we have this guy right here. That's the thyroid cartilage. This you can feel. And still further down, there's an other cartilage here called the cricoid cartilage. If you're wondering what's the difference between cartilage and bones, cartilage are usually more flexible, right? Like your ear is made of cartilage, right? Part of your nose is made up of cartilage, whereas bones is much harder, right? And over here, we haven't really talked about it yet, but we will soon. These rings, these are cartilage rings. Around the trachea. To keep it open. We do not want the airway to collapse too close, because then we won't be able to breathe. To keep it open, we need the cartilage rings. Okay. So I have a YouTube video to show you. There we go. You can see this is X-ray, and the person is chewing. And take a look at what happens when the person swallows. Okay, did you see that? Right. Let me play a little bit longer. Okay, see if you can find the epiglottis in this video. Do you see the epiglottis? Oh, I think is swallowing liquid now. Okay. Right here, that little line right there. That's the epiglottis. Okay, and you can see this is the thyroid cartilage, and then you can see when the person swallows, the larynx actually pushes up, and it gets sealed by the epiglottis. People sometimes have this misconception. They think the epiglottis goes up and down like a toilet seat, but the epiglottis actually stays in place, but the larynx pushes up and gets sealed. You can put your hand on the throat and swallow. Right, try it. You literally feel your larynx pushes up. And so let's see that one more time. Look, this line here, that's the epiglottis. Let's see what happens when you see that. Okay. So that is that. Let me give you the link if you want to watch it again later, or if you want to show other people. It's in the chat box now. Okay. So during swallowing, oh, it's also here. I didn't remember. During swallowing, the epiglottis is going to be pushed against the larynx, because the larynx is moving up, and it's an elastic cartilage, prevents the food from going into the larynx. Now, your vocal cords are found within the larynx, and the vocal cord are a little bit elastic, stretchy, and it's actually skeletal muscle, meaning you have voluntary control over it, which totally makes sense, right? Like, because you can control when to talk and when not to talk, right? And you can control the pitch of your sound, high pitch, low pitch, all that is voluntary control, which tells you the vocal cords are actually skeletal muscle. when the vocal cords are tight, then it's going to give a higher pitch. When the vocal cords are loose and wide, it's going to give a lower pitch. Okay, so the way to produce sound is to have air going through the vocal cords and causing it to vibrate. Think of it as like a wind instrument, like a trumpet or something. If you don't blow air into it, it's not going to make any sound, right? So in a similar manner, if air is not moving through your vocal cords, no sound can be created. Here is something you can try right now. Okay? You can try to close your mouth and pinch your nose. Close your mouth and pinch your nose and try to hum a song. Right? Try to hum a song. Right? You can't do it. Right? If you close your mouth and you pinch your nose, air cannot come out. No air is moving through the vocal cords. No sound can be created. Right? So in order for you to make a sound, there must be movement of air through the vocal cords. I have another video I want to show you. If you're easily grossed out, then maybe like cover your eyes or something like that. Let me see if I can share my sound. There we go. Now this is called laryngoscope, okay? Laryngoscopy is when you look at the vocal cords of a person. Okay, so here we go. Can you guys hear the sound? Can you let me know if you can hear the sound?
Yes.
Yes, okay. So I want you to pay attention to the sound she's making, okay? She's gonna go like low pitch and then she's gonna go high pitch. Take a look at the vocal cords and see how the shape changes. Right, you see it's very thick right now, right? Because she's doing like a right, like a very low pitch sound. Okay. Now you see how the cords are like pulled vertically and make it thinner when she does the high pitch sound, right? Now you can see when she takes a breath, like it opens up and you see the rings here, the ridges here. Those are the rings that surrounds your trachea, your airway. How about this thing right here? Can anybody tell me what this thing is? What is this? Do you guys see my mouse actually?
Yes.
Yeah, okay. So, yeah, so what is this thing? Come on, tell me. It's something that we talked about already.
Thyroid cartilage.
Oh, okay. The thyroid cartilage is like further out. Okay, it would be like maybe down here. But good guess, good guess. Another guess? What is this? What is it? Sorry, you got cut off.
Epiglottis.
That's right, the epiglottis. Excellent, right? The epiglottis, which, in case you forgot, is this thing right here, right? Okay. So the epiglottis is not covering the airway right now, which makes sense because you're trying to make sound, right? When you make sound, you need to let the air in and out. Okay. So you see again, low pitch is very, very thick. Anyway, that's enough of that. I will give you that link as well in case you want to take a look. Sorry, go ahead, Aminette.
Okay, yeah, the video is that like further down the throat or
Which one?
the video, the YouTube video?
Oh, the video. It's just like around this area. Okay, around this area. Yeah. So they have to take it's called endoscope. It's like basically like a snake-like thing, and they stick it up your nose all the way through, right? And it's gonna basically hold on. It's gonna stick it up through the nose, the camera, and it's gonna go through the nasopharynx all the way to here. The video we were looking at like right here. Like the camera is like right there looking down. All right. You know how I know? Sorry, go ahead. You had a question or comment? No, you get it, right? That's where we're looking at. Yeah, so you know how I know? Well, I had one of these things done to me when I was, I think 7, okay, 7 years old. And it like totally traumatized me, right? So what happened was apparently, according to my mom, like I had these tantrums as a kid, and I like to scream a lot, and I screamed so much that my voice became raspy. Right, it sounds like, I have something stuck in my throat almost. So then she took me to these one of these throat doctors. Okay, these specialists. And then the doctor stick a camera up my nose basically, and I don't think it was a very good doctor because he didn't really think about my feelings. He was sticking up the camera up my nose, and then the whole time I was able to see what's going on the screen that he was looking at, right? So I was really grossed out. I was like, oh, that's what it looks like inside. And I remember him, sticking the thing further and further in, and then finally it got to the vocal cords. And on my vocal cords, there was a little knob that was growing on it. And then the doctor's like, that's what's causing the raspy sound, right? Your son has a thing growing on your vocal cords. And then, of course, I remember my mom asking the doc, oh, no, like, what are we going to do about it? And he said, oh, it's easy. He just needs to stop talking for a couple weeks, and then it will go away, right? So afterwards, my mom was like, oh, you heard the doctor, right? No more screaming, no more yelling, right? Otherwise, we have to stick the thing up your nose again. And I think it was a really effective treatment, I guess. I did recover, as you can tell. My voice sound reasonably okay. Yeah, and that was a laryngoscopy. If you ever need to check out your vocal cords, gonna go up your
I
nose.
have a question, Professor.
Sure, yeah.
I heard from singers. They
Singers, yes.
said yes. They said they lost their vocal and they stopped singing. So
Yes.
what is the problem? Yeah.
Sometimes singers, right? They I don't know if you know who Adele is, right? Like Adele is like a really famous singer, right? So she, hitting all the high notes and stuff like that, it basically put a strain on the vocal cords, and some of them actually need to do surgery to repair the vocal cords, right? Basically, the vocal cord is like any muscle. If you overstretch it, it's gonna get strained, right? And it could affect the quality of the sound they produce. So sometimes singers, they have to do surgeries. Yeah. Okay, what happens if the food does go down the wrong tube? Right. So first of all, if you see someone, you're eating with someone, and then all of a sudden they start like coughing a little bit, like like that, and then the universal sign of like I'm choking is like they put the hand like around their neck, right? Okay. So if you see the person coughing, you should not pat them on the back. Like I remember my grandma likes to do that. Whenever people start coughing at a table, she just pat them on the back, right? Patting people on the back is going to make it worse. It's going to cause the food to go further down, right? The coughing is a mechanism to try to get the thing out, right? By coughing it out. Right? So, you can ask the person like, are you choking? And if the person can answer you, it's like, yeah, I'm choking, right? If they can talk to you, then that means they're not choking yet, okay? Because I just told you, if the airway is blocked, that's what choking is. If the airway is blocked, then air cannot move in or out. That's why you can't breathe. But if you can't breathe, that means no air can come out either. And if there's no air going through your vocal cords, you cannot make a sound. So if the person stopped coughing and then they can't talk and the face turns red, then serious now. Okay, so call 911 if you need to. And if you are CPR trained, then you might have to do the Heimlich maneuver on them, okay, which basically involves compressing the abdomen of the victim, and that compression is hopefully going to increase the pressure enough to dislodge the thing that's stuck in the throat. If you're alone by yourself, then you might need to use the back of a chair to simulate the same kind of motion. Okay, so Heimlich maneuver. I think for you guys to go into nursing, you have to have your CPR certification, right? So I'm sure this is something that you will learn later on. Before I was a teacher, I used to do research at Sick Kids Hospital. I did some like research on like brain stuff. Anyway, in the hallway of the first floor at Sick Kids, the children's hospital for sick children, right, at downtown, they have these frames that they hang in the hallway. Okay, I don't know if it's to scare the parents or scare the kids or what, but like I walk by every time I see that, I just find it to be quite interesting, and I took a picture of it. These are the things that they took out of kids over the years, right? From the airway and from the food passageway, and it's kind of crazy, right? The kind of things that kids put in their mouth and nose. Right? Like some of these things, like I guess I can understand why they would get stuck in the nose, but like bobby pins and stuff like that, apparently they swallow those things as well. Hopefully, when they swallow it, it wasn't like popped open, right? So, again, if you ever at downtown and you just looking for a place to check out, maybe you can go into Sick Kids Hospital and try to find this picture. The frame, right? This is the picture I took of the actual thing, right? It was actually hung on the wall. I don't know if it's still there. This was like many years ago. Okay, vocal cords. Where do we find the vocal cords? Please tell me. Where do we find the vocal cords? All right, very good. Most of you got it right. The correct answer is the larynx. Larynx. Okay, what is that? What is that? That is the Adam's apple, right? Which is formed by the thyroid cartilage. Okay, thyroid cartilage. The answer is C. Done. That's it. I think we are halfway, so that's
I have a question.
yeah, go ahead.
Yeah, so I wanted to ask, why did they put the, the snake thing, like through your nose and not through the mouth? Like I think
Oh
it's
yeah,
closed
yeah.
and-
It's the snake thing is called endoscope. Endoscope.
Yes.
Yeah,
Okay.
endoscopy. Yeah. They do it through the nose and not the mouth because when you stick things down the throat, you gag, right? Like,
Oh, okay.
like that, right? Okay, and then they
Okay.
don't want you to feel distressed. So it's more gentle up the nose, basically.
Okay, no, thank you.
Yeah, good question. Okay, so I think we're gonna finish up the stuff next time. Okay, and I want to give you guys a moment here to see if you have any questions you want to ask from lecture 3 or 2, especially the study guides. Okay, is there anything in those study guides that you want me to talk about? Is there any specific questions or some concept that you want me to go through with you? Now is a good time to ask.
Vincent, I don't know if it's relevant or not, but I have a question about lab
Okay.
one.
Yeah, sure.
So you said somewhere in content tab, there is something that we have to do it first and then go for the lab. I want to see that one.
Sure. So if you go here in the course, okay, I haven't give you the link to the lab yet, but if you want to do it, content, lab, and then lab 1 right here. So you want to start working on that. Okay.
So it's about like cardiovascular system, right?
Not just that, it's the whole first unit. So not just the heart, but there's gonna be like
Oh,
yeah, blood typing. There's gonna be some graphing some lung stuff as well. Okay. In fact, I think you guys should do this. We will have time on Thursday to take this up, okay? But I want you to try it out first. Okay. So I'll post a link at the end of class, so that I can redirect you here. All right. Now, any other questions you want to ask me from the study guide, lecture 3 and 4, 2 and 3 rather? Is there anything here that you're not sure of and you want me to take up? Okay, why don't I give you a moment to flip through your stuff? All right, I'll hang around for about 5 minutes or so and see if you have anything you want to take up. If you don't have anything you want to ask, then that's it, you can go. Okay? But if you want to just go through the stuff quickly on your own, flip through it, see if there's any question you want me to take up, now is a good time. I guess maybe some of the application questions. Would that be something that you guys are interested in? Take up the application questions? Yes, no, maybe. Okay, I guess that is it then. Maybe you guys need to go through it on your own first. If you have anything you do want me to take up next class, send me an email and I'll be sure to do that. I mean, the answers are all posted anyways, so you should be okay. But yeah, that's it for today. Take some time now to work on the lab. We will take it up on Thursday. And yeah, I'll see you guys next time. Okay, have a good one.
Thank you.
Bye-bye.
Thank you.
Thank you, Professor.
Yeah, no worries.